We are live. I will come here.
Does that mean Keisha's there too?
Yes. I don't know. I believe so.
Okay, but tell them I'm working on the property tax and I have 3 members here, so you may get a minority vote on the bill.
I'll let them know that.
Okay, we are live. Apparently, this is Senate Finance. This is February 15th. We apparently have had several members called to the principal's office, meaning the pro temps. So I'm sure Senator Brock will be here in a minute and we're gonna work our way through. We're gonna start with S-230, which is the Medicare Advantage and Supplement Insurance Plans. And we have Kelsey Madden. And Kelsey, just introduce yourself, welcome. Tell us who you are and who you represent.
Thank you. For the record, my name is Kelsey Madden. I'm the Managing Director of Medicare and Partnerships for MVP Healthcare. Thank you, Chair Cummings and the Finance Committee for the opportunity to comment today. Our comments are primarily going to focus on MVP's Medicare Advantage perspective and our approach as a regional non-for-profit health plan, and focus on Sections 6 and 7 concerning broker commissions in Medicare Advantage. My colleague Jordan St. is here as well, so we're happy to answer any questions at the end.
Okay.
Thank you. MVP has over 30 years of Medicare experience. We merged with one of the founding Medicare plans that was in Rochester, New York. They were one of the inaugural managed Medicare plan contracts that was awarded in the entire nation. Through our 30 years of experience, we have found many seniors have fixed incomes, and Medicare Advantage plans offer $0 premiums to seniors. We have 3 plans right now in Vermont that range from $0 to $130 in premium, and approximately 80 to 85% of our membership in Vermont is concentrated on the $0 plan. In Medicare Advantage, you get all of the services that you're eligible for under Original Medicare, in addition to extra supplemental benefits. These include things like some dental, vision, and hearing care, and some MA plans also provide coverage for gym memberships, meal delivery, or transportation to medical appointments. Additionally, many Medicare Advantage plans include Part D, which is prescription drug coverage that's not included in Original Medicare. All of our Medicare Advantage offerings in Vermont include Part D. Lastly, Medicare Advantage plans have an annual cap on max out-of-pocket expenses, unlike Original Medicare. Our Medicare Advantage plans in Vermont are tailored specifically for the needs of Vermonters in rural upstate New York. So, for example, most recently in the past year, we increased our transportation benefit to 60 miles each way for healthcare appointments after receiving feedback from the greater provider community about the average distance to travel for appointments. The physicians that are seen in our Vermont marketing campaigns, they're not paid actors, nor are they volunteers for commercials. These are actual members of our clinical advisory committee that meets once a month all year round to provide input on product design and delivery. These are the providers who are actively engaged and at the table advocating for what their patients in Vermont want and need in a Medicare offering. When we entered our partnership with the University of Vermont Health Network, we studied over 1,200 Medicare eligible consumers in Vermont and Northern New York. We discovered what they want when selecting a health insurance plan, that some of their highest unmet needs are related to understanding. So understanding the information in the quoted plan, understanding the services. In Vermont, we have 3 employed sales representatives. They're licensed to sell Medicare Advantage, Catherine, Jorg, and Zach. These roles are called plan guides. This is intentional because these employees are onboarded in a specific way and trained to be guides to help consumers understand all of their options. In addition to our employed sales force, we partner with licensed Medicare brokers. This past annual enrollment period, about 26% of our new Medicare Advantage sales in Vermont and Northern New York were from about 40 locally based independent brokers. We find in our experience that many seniors look to brokers and financial advisors for advice when they age into Medicare. In our consumer data, we found that the top unmet need related to understanding plan information, when you ask consumers, who do you go to for help and understanding, the top response was a trusted resource like a family member, friend, broker, or provider. We find that our customers in Vermont and New York prefer to work with brokers because Medicare Advantage is just one Medicare option. Brokers help to navigate all of the different choices, so not just MVP or UVM Health Advantage, other carriers, and not just MA, MedSup, Part D, and all of the other options when you turn 65. Broker payments in Medicare Advantage are unique. They are prescriptive and regulated by the federal government, and it's different than how fees and commissions are paid for commercial products. So there is the same fee schedule in Medicare Advantage for a new to Medicare enrollment or a Medicare renewal across all health plans. In our experience with local brokers, they tend to match consumers with strong customer service-oriented MA plans. MVP opposes Section 6 and 7, which would effectively prohibit the use of brokers in Medicare Advantage sales. We do share concerns about deceptive marketing and sales tactics, and we fully support the federal government and their work to continue to strengthen MA marketing and sales rules over the last few years. The bad practices are not ours, and we do not support seniors being sold Medicare products that do not meet their financial and health needs. In conclusion, we take great pride in being a regional non-for-profit health plan. We don't have investors or shareholders. Our shareholders are our communities and local partners. We live, work, and play in the communities that we serve. We have nearly 30 years of Medicare experience, and we believe that Medicare Advantage presents a great option for seniors' healthcare needs, and that trusted community-based resources like brokers are a vital resource for senior consumers to understand all of their healthcare options. We are concerned about Section 6 and 7 and urge rejection. In Vermont specifically, we've partnered with another regional non-for-profit with shared values and vision. We use Vermont-specific consumer data and continuous provider feedback to design our Medicare Advantage offerings for what Vermont consumers want and need from a Medicare plan. Thank you for the opportunity to testify and for consideration of comments.
Okay, so you
So thank you for that testimony. I hear you were most concerned with 6 and 7. I recall others' testimony really focused on Section 4. By you not speaking to Section 4, are you comfortable with what they're proposing on the community rating, disability, and Medicare supplemental health insurance policies?
We do not currently have a position on Sections 1 through 4. We do not currently offer Medigap and SUP coverage, and we're not a Medicare Advantage partner for the state employee program.
I understand. Thank you.
I think
Thank you for the question.
the biggest concern we've heard is that people are on a Medicare Advantage plan, and then it seems to be, you know, you get your dental, you get your eyes, everything, but then you get to a point where you have a serious illness. How many, cardiologists are in your range? And they need somebody, and they don't want to have to drive to Boston in Vermont or in the winter in a blizzard, and so they come back to Medicare, and it's cost of getting back in that. And we've heard adverse selection and trying to keep everybody's rates down, but what happens if someone decides to leave your plan? Is that facilitated at all?
It's a great question. So I can speak to it broadly, and then we can also go back and get you more information. One of the unique things about our plan, the UVM Health Advantage product, is we offer a specific role called care guides. Care guides are intended to help consumers navigate those sorts of experiences. They do also do a lot of proactive work today with consumers to help them stay well. If you get a diagnosis like cancer or a new illness or disease, the care guides work directly with the consumer to maximize their plan benefits. There's obviously always the option for the consumer to switch during the annual enrollment period if the plan doesn't make sense for them. Most recently, something I was involved in 2 weeks ago, We had a Medicare consumer in Vermont that approached us regarding looking for an appointment with a neurologist. And she had called some providers in the area and found that they were not accepting appointments until December of next year. We quickly mobilized a team at MVP between our provider relations team and our care guides to identify other options for this consumer within a 30-minute, 40-minute drive of her home, in addition to covering the transportation through her benefit. So then we worked directly with her to get an appointment that was quicker, and then also make sure that she understood that she had transportation benefits to see that specialist.
Thank you. That is helpful to understand. Okay. Any other questions? And you are associated with the UVM plan? I assume you are the UVM planner.
Yes. Good question. Yes. I also oversee the partnership with the University of Vermont Health Network. So our plan that we offer with UVMHN is the Medicare Advantage product. So the Medicare Advantage product that we have in Vermont today is partnered with UVMHN.
That's impressive if you could get someone an appointment in 4 weeks, because 6 weeks is sometimes the least amount of time it can take to get an appointment at UVM. So it's impressive you could work that out. Okay. And you are not for profit. And
Correct.
because I'm wondering, how can you offer a plan with no payment from the consumer? You said you have 0 payment plans. How do you afford those?
Good question. And Jordan, feel free to jump in too if you'd like to add context. From a Medicare Advantage perspective, the way that the funding works with the federal government is that at a really high level, the plan is putting in a bid for a certain community to provide a plan. And it's supposed to be at or less than the same rate as what the fee-for-service cost is for the federal government. If you are able to provide those services for less than the fee-for-service rate, you're able to reinvest the savings into supplemental benefits. So that's how you're able to afford those extra things that are offered within the plan. And Jordan, feel free to add to that if you think there's other context that would be helpful.
Jordan, we can't hear you. Zane, have we got Jordan muted at all?
He is muted. I can't unmute him.
Okay, looks like you're unmuted now. No, we still can't hear you. You're unmuted at our end. Nope.
Can't hear you, Jordan.
Technology is wonderful till it isn't. Okay, I think we're past our technical difficulties.
Sorry about that.
No, it happens with fair regularity around here.
I would be in person today, but my team's actually in Montpelier at the Senior Activity Center today cooking congregate meal. But I had a doctor's appointment this morning, so I was like, "Oh, it's the one day that I'm there."
Okay. Any other questions at this point? Okay, thank you.
Thank you. I really appreciate it.
All right. So, committee.
Maria coming in at 2.
We have Maria coming in at 2. So she's not on here. Next.
Oh, I don't have you copy.
You have a new one. All right. This is agenda as we go. All right. So she's coming in at 2 to go over the amendment for the CUV merger. S-199. And I would like to vote that out at the end of today. And then at 2:15, if you drop Maria an email, she might be able to, if she's not tied up.
I told her we would be available from 1:45 to 2:15, and she said I can be there at 2.
Okay,
So.
so she knows we're waiting for her, so we're waiting. And we're going back to 2:30 at 2:15 for Jill Olson-Maza of the BNAs of Vermont. And then we're going on to 8:50, which is what I hope we will do for the next 2 days, and my goal would be to vote it out on Friday. I think we will be getting, if we vote the housing bill out tomorrow, which is the plan, bar negotiations between these two chairs, we will get it because there's several tax pieces in it. I assume by Wednesday, it's on, your calendar, you'll notice it will be here on Wednesday. And I'd like to go through that. We had taken out a couple of tax proposals, and at the tax commissioner's request, housing put it back in. I didn't give him a favorable indication, he would like to have it go with us. So, we're getting it for that. There's tax credits in there. Randy, can you think of anything else we've got in there? There's tax credits. The downtown tax credit is going up,
Anything else off the top of my head? I'm sure
and a
there's-
couple of tax. There's something to do with the tax credit to put low-income housing in downtown. I do not remember that one, but the people in the state who are responsible for those people say that's the housing where our people, meaning the homeless people, are gonna go, so they would like to keep that. We'll look at all of them. And then. Okay. Yeah, so we're gonna start, and then after we take care of the 127 debacle, we need to start doing some work on the property tax increases, and is there anything we can do to prevent that? What can we learn from what's happening? I'm now getting, apparently Stowe has reduced its budget by over $1 million. They want to know where's the equity, because if they reduce and Montpelier and several others don't, everybody's going to get a tax increase. And I think we need to talk about that. It has been mentioned, the thing that kept everybody honest when they were misinterpreting the 5% cap was that you had to go to the state if you went over 10. That might be something.
Well, there are a whole issue of things that cause this debacle. Not the least of which is incomprehensible tax system that, on which we need to do a lot of work.
Yeah, I think we do, and the tax system we have is a result of Brigham and our desire to maintain local control, and
The two are obviously
avoid the
conflict in situations.
funding failures of previous systems.
yes.
Yes,
Which were.
but it's also the issue of doing what the Blue Ribbon Tax Commission wanted to do and purported to do in 2010 and 2011.
The second.
And that is recognizing that when you have a tax system in a state like Vermont, and you're dealing with three major types of taxes, if you fool with one, it has an effect on the other. And so the notion was that we're going to take a look at the tax system at one time altogether and reconcile it so that these interactions between taxes and between localities need to be done in a logical way that works. And the first tax commission did a great job, but they only dealt with two of the taxes.
Yes.
So we didn't come back to deal with the third tax. Now, we did something somewhat later that was not effective and was not as thorough as the first system, didn't produce
Yeah.
multiple reports, which that one did,
Yeah.
both a majority and minority report. And was much more in depth than what we've done afterwards. And we've never gone back and really looked at this as one. And as a result, we have an education funding system that virtually nobody, including the people who wrote it, can effectively explain.
You got a couple hours?
Yeah, and you still won't
You
get
can
it.
explain it. I think I could do a decent job of it, but it gets very
Anytime you have a tax
complex.
system, which to
Right.
explain it, you've got to use the coefficient of diffusion. It tells you you do not have a comprehensible tax system.
No, it is not comprehensible. It does what we wanted it to do. It maintains local control towns, districts vote their budgets. We do the Brigham, we equalize it, and then everybody rises or falls, it's never fallen, rises together. It is complex. Can't get around a Supreme Court requirement. So, you know, I think we get a lot of resistance with doing away with local control.
Well, you get a lot of
So I-
resistance, but I think the other thing that you've gotta back up and really look at is, the small size and the continuing decline of student enrollment in Vermont. And maintaining the system that was built for much greater enrollment is exceptionally expensive. That's why we're one of the
Yeah.
highest expense per pupil
It is.
systems in the United States. And the question that we all have to ask ourselves is, can we continue to afford that? Because the effect we're seeing and we will be seeing this year on a tremendously high tax increase, regardless of what we do in one way, shape or form, that's going to affect people.
Oh, it is, and it's going to increase our homelessness, it's people getting taxed out of their houses. Yeah, it's, where do we start? Having been a veteran of the merger bill, which was a tripartisan and unanimous vote, we had limited success with that. Stowe, who's been one of the chief groups concerned about the 5% cap and doing away with it. They said they're still merged, but they have a separate school board, yeah. So they did not want to be in, and we've had a lot of people like their local schools. And in towns where there's enough wealthy people who can afford it, they will keep them.
But we have this
It's
also
been-
in towns where there aren't enough wealthy people to afford it, and that's what we're gonna be seeing, I'm afraid, in this tax system, in this tax season.
Yeah,
Well, that's what
I spoke at a school, in Frederick County a couple of weeks ago in class, and there were 7 kids in the class. And the question is, we know that people may love that, but, you know, 27,000, 28,000, 29,000 a kid. I just wonder, as I've said before, when we have, you know, 1 kid in school, what the cost per pupil is gonna be.
I mean.
And that's what's
it's-
happening.
It's
We had one
same
place,
issue with Vermont dairy farms.
we had 4 kids in
We
a
did that at
kindergarten
one
class.
time, we called for competition.
And couldn't, school parents wouldn't allow them to be transported to a school in the same district. That's pretty close to hiring a private tutor. And our size and our lack of population is one reason. And when all you had to do is learn reading, writing, and arithmetic to be an educated person. But you've got to know robotics and computer programming, and some schools get it and some schools don't.
Well, the other thing is, you know, in some cases, our education cost is distorted because of the amount of things that we are asking schools to do and the amount of social service spending, medical and related spending that now is under the umbrella of education, and whether that's really education or social services that we perhaps at least account for differently so that you know what you're spending and on what.
Well, I know we did a lot of work with Medicaid and special ed, which is where we were seeing a lot of the assistance, para educators. But we haven't had a lot of success. I think we have to own that we have not helped our local mental health agencies who are, they're designated agencies, they're arms of the state. And their former director did a very impressive display for some of us several years ago, that if their pay had risen at the same rate state employees' pay had gone up, where there would be, this was maybe 5 years ago, it was pre-COVID, but they were offering $35,000 for a master's level job. They were having a hard time getting people, and now the housing crisis has, you can't get people to come here because you can't pay them, they can't find a house. So we have issues,
No, Chair,
yes.
we're going around in circles here. The education systems are like funding is like any, like, is redistributing wealth, like most of the discussions that we have,
Yeah.
which are the redistribution of wealth. And
that's unfortunate.
we've spent 40 years redistributing wealth upwards. And we're sitting here now saying that the school funding system has problems.
I think I will give you the name of the man from Stowe. I spent half an hour with Saturday morning explaining why 2/3 of Stowe's taxes go to poorer towns. This does redistribute the wealth, but it's not up.
We have spent as a nation
It's a nation.
redistributing wealth up.
Yes,
And if it weren't for the current funding plan, you wouldn't have gotten a half an hour of man's time.
No.
That's an uncharitable thing to say, so I take that back.
it's probably true. People only call me when they're mad. Okay, I had Senator Chittenden, and then I'll do Senator
I
Claus.
think this is a very
We're still waiting for Maria.
important fundamental discussion, and I do think that it's the tension between local control and equity, but I will say in my 3 years of diving deeper into this, that equity keeps getting confused between taxpayer equity and equitable access to educational outcomes. So,
It's not the court decision.
right, there's
Equity to access to tax base. It's the court.
Yes, but
So my concern is that we have that centralized the funding, but decentralized the decision making. And I think what that's creating is not just perverse incentives, but disincentives, where prior to Act 60, in communities like South Burlington, if you wanted a new high school, you would work with the city to upzone, to attract more development so that you could get more tax revenue that would then directly offset the cost of that building. But now with Act 60, it has, you don't get that benefit because that tax revenue gets pooled into the rest of the state. So there's no incentive to grow the economy to offset additional burdens and costs. Now, that being the case, I think we need to look at the formula of funding a little bit more, but we also, really important, and I think Senator Brock would agree with this, is we have to look at the spending in the schools, because we cannot have equitable access to educational opportunity and local control. We need every district to report consistently what they're spending money on so that we can look statewide at where those inequities are and what their methods are, what their resources are, what their outcomes are, and what their expenses are. Because we as a state, we're pooling all this money, we need better visibility into how they're spending that money, because Act 127 isn't doing that, doing that at all.
no, that was just waiting. That was just,
Just the funding part.
yeah, I mean,
That
that
was
was,
the redistribution part.
but.
I would like to go back to that common ledger that I guess died on the vine, but I feel like that's what we need to
Common
do.
ledger has been on discussion since I entered this building. We haven't gotten it yet. We don't know what the average spending on fuel or the average spending on anything is. But I think, yeah,
But systems and software have gotten better and more mature, so I think just because it hasn't worked 5-10 years ago, doesn't mean it won't again, so I think it's well.
we
worth
have
it.
things like computers and,
So is there a motion to go back to the foundation plan?
no, there's a
So
motion
moved.
to stop this off the cuff, thing because our next witness is here.
I'm just gonna get my iPad, it'll be
Okay.
20 seconds.
And Maria, I'm hoping we can get a bill out of here.
Still.
Hello. Maria Royal, with the legislative council. And we, this is a draft amendment on S 199, the CUD merger governance bill. I believe it's posted online, but I also hard copy. It's only one page, double sided.
I get told. We can't vote. Several people will talk to the principal's office. Something about a housing bill.
Can't imagine.
They will be back. You can have one of these for the record. I don't know what's going on.
Susan, before we get started, I just wanna say, I hope at some future time, we'll have a discussion on that same issue.
Oh, we are gonna have.
But you might wanna hear from the majority leader when we pass Act 60. Okay,
That's fine.
okay, I got kind of
I
squeezed out.
thought I had the minority leader or something here. when in there and referring to that 60. I was just in the building. Yes, we will hear from everybody.
Okay.
First, we need to clear up the 127 mess, then we're gonna go into the system and what's happening for better for us. But this is CUDs.
It's the CDs, and it's an amendment to just one section of the bill, which concerns the treasurer of the CUD and the authority of the treasurer to delegate any duties specific to that office. And I think you wanted to tighten up the language a little bit. So on page 2, the proposal now reads, the treasurer may delegate authority to perform any or all of the duties described in this section, provided such delegation is approved by the board or authorized in the district's bylaws, and further provided the treasurer retains accountability and oversight authority for any such delegations.
Great.
Work. Okay.
And I will say, I did just quickly run it by Tucker and Tim. And the only thing that Tucker brought up, I don't think it's a problem here. But if they tried to delegate to an auditor, right, because they have to do an audit, like that's an incompatible, but the auditor has to be an independent professional accounting firm, so I think you're covered, but that was the one thing he said.
Yeah, you could delegate to the guy that was on.
Correct. Yeah,
Delegate to the other.
yeah, so I think you're,
Okay. Any questions? I will put this on for a vote tomorrow. We think our witnesses for tomorrow may be canceling because they think maybe they should be talking to GovOps.
They shortened their time, but they've been replaced on the agenda.
Okay, so got some time. So we will put 199 on for vote tomorrow.
I believe it's on the copy.
It is already on there. Okay. Thank you, Maria.
you're very welcome.
That moves up, right? All right, next is Jill Mazza Olson. Jill, we are back on 230 Medicare Advantage plans. Jill, I see you a lot when I was on health and welfare. You don't usually get here, so
I'm not sure I've been here in this role, and I've been in this role for 7 years.
I don't think you.
We did have that little pandemic.
Yes, there was.
Coming, you can't stop.
Is that what it is? Okay, okay.
Did we improve your internet connection?
You did, actually, you did. Yes, you did.
I
So
remember those
Oh.
meetings with your face.
I would say I live 3.5 miles from the State House, so I don't know I have decent internet, but I do now. So I'm Jill Mazza Olson. I am the Executive Director of the VMAs of Vermont. So I represent home health and hospice agencies. Before my job with home health and hospice, I would work for the Hospital Association for many years and sat in this chair on their behalf too. So I've just done a lot of healthcare in my job.
We haven't done, we don't do a whole lot of help.
Yeah.
Except when we were changing help.
Exactly, only when we're changing it. So just before I start, I wanted to just give you a little bit of an overview and reminder about what home health agencies do, because we're talking about only a portion of our world, and it's important to just distinguish. So I do this actually when I talk to any audience, just to remind people of the different components. So home health agencies provide medical care at home. That is actually one of our most substantial services. We provide nursing and physical therapy services on a short-term intermittent basis for people who actually have treatment goals and an expectation that they will actually improve over time from the care. So this is often post-hospital discharge. So, but sometimes actually we get community referrals as well. So this is this critical role that we play in the system. When you hear hospitals talking about the importance of being able to discharge patients, 16% of hospital discharges are coming to skilled home health. It's probably maybe 18 to 20% going to skilled nursing facilities. So it's a very substantial part of what hospitals are relying on when they're thinking about how to get people who don't need to be in the hospital anymore, but who aren't ready to be home by themselves, to get them out of the hospital and into services. So that is our medical service, and that's what Medicare Advantage actually touches. The other things you hear about in this building that we also do our hospice, so we do end of life care for people who are at the end of life. That's a holistic service provided anywhere, lots of settings. We also provide maternal child health. And we also provide long-term care. And people hear about that a lot from us because it's a Medicaid program, and so the funding is especially relevant in this building. But it's actually sort of not our primary service, but it is something we do. So that is care for people over long periods of time, keep them independent in their homes when they can no longer do all the things they need to do.
Choices for care.
Choices for care, exactly. So that's help with bathing or dressing or nutrition. Doesn't need to be done by a nurse, certainly by someone who's trained, and it's a critical part of our system. I'm also not talking about that. So back to Medicare Advantage, what I'm talking about is our skilled home health service. This is what it is affecting right now. It may eventually impact hospitals as well, but it doesn't yet. So home health agencies are really reliant on Medicare funding. It's their primary payer. When I look at, we've started to actually break out Medicare Advantage from traditional Medicare. And I have that data from some, not all of my members, but where I do have it, at this point, we're at about 66% traditional Medicare, so the people we're taking care of. 19% on Medicare Advantage, so this is mirroring the national trend and what's starting to happen in Vermont. 7% Medicaid, 8% other payer. So we live and die in this program by what Medicare does. It's critical. And the reason we're interested in talking to you about Medicare Advantage is because it is becoming probably the most substantial threat to home health services that we have, because of the rates that are often paid by some of the plans. So, and this is actually, I also facilitate a group of providers, trade associations, and this is something that is true in the physician world, the hospital world, the nursing home world, lots of providers having this issue. So when I look at, I will leave with you some of the things that our national association is saying. But what's really common, so, and let me just say this, the plans are all different, so it's not uniform. And some of them, they definitely are different. But what we're seeing is that enough of them are doing things like for home health, paying us at the what's called the LUPA rate, which is a lower fee for service rate than our traditional Medicare rate. It's about 75% of traditional Medicare. So they're paying at a rate in that neighborhood or even lower potentially. And so we're taking this payer that we rely on. We don't have a cost shift, we don't have much of a commercial base. And we're seeing the reimbursement rates migrate to these lower paying plans. So that's why it's really concerning in terms of our ability to provide services. And what we really need is a policy solution in Congress. So we really need Congress to help.
We can't.
There's a limit to what you can do.
Yeah.
Absolutely, there's a limit to what you can do. And what we really need, and actually it's why our national has like a regulatory piece on this and a legislative piece, because CMS and Congress are actually not even in total agreement about whose job it is to do something about this. So it's a mess. So we really need a federal solution, but we're interested in anything we can do at the state level to address some of the concerns that we see in Medicare Advantage. So this is why we're interested in the provisions of the bill that allow for things like the community rating, so that people realize that they're in a Medicare Advantage plan they don't want to be in, they're able to come back into traditional
I
Medicare.
think what we're hearing on that is, again, the concern of adverse selection. And if, you can get your teeth and your your
Right.
eyes done for 20 years, and then you develop heart disease or cancer and you want to come back, I don't have to tell you that the risk is much greater.
I think what bothers me about that, I looked at that testimony, I listened to some of it, is that what does that say about the benefit that's being offered in those products?
Oh.
If when you get sick, what you want to do is go back to Medicare. So I was actually sort of disturbed by some of that testimony.
I would be disturbed, but
Yes, so No, I mean, I guess I want to, I guess it sounds like there's some data available on what it looks like when states have done that. I think it would be interesting to see an analysis of what it would look like in Vermont. Potentially, especially with the work that's happening upstairs with migrating more, or potentially expanding the Medicare, savings program, which
Yeah.
will impact some of those folks.
Okay.
Yeah, so I didn't see that you had an Vermont analysis of what
No,
this would
I
look like.
mean, we haven't. I think the most disturbing thing is to find out what we are prohibited from touching. And I think I felt better knowing that Blue Cross has a guaranteed issue.
Mhm.
And it is more expensive because it's higher risk,
Mhm.
but there's at least an alternative that isn't a ripoff.
Yes, so I saw that. I guess my question is, I mean, it sounds like if people have made a price choice to move into Medicare Advantage because of the price of the supplemental plan, not sure that they're gonna come back into that guaranteed issue plan. I'm a little skeptical that that population will feel like they can do
I
that.
think that we also heard, I mean, they have zero pay, and for people that don't have very much money, that's very enticing. And they
Yeah.
might,
Yeah.
I mean, they will get the same care they'll get from Medicare.
Mhm.
And it just might have, you might have to travel further. Depending, it sounds like if you get some of the local not-for-profits, you're probably in better hands than you get from the national for-profit people. But it's a mess.
Yes, it is, it's definitely a challenging problem. This is also why we're interested in the language about the advertising, to make sure that people really understand what they're doing. I mean, I can tell you, I don't think my husband would understand what he was doing if he did this. I don't need to throw him under the bus on the record, but
I'm not sure.
Too late.
it's much too late, yeah. Yeah, and so I think people don't fully understand. I've certainly gotten calls from the aging parents about, what should they do? And he's gonna be my husband will be on Medicare in a few years.
We had DFR in last week, I guess. And they were encouraging, they are really working to do, they've got a website, but going to start working with the Office about Aging to be able to get information out to people who suddenly turned 65. And we didn't go on Medicare at 65 because my husband's job was still paying our health insurance.
Yeah.
So,
Yeah.
all of a sudden, I know more than I think most people do, or I should. And,
Yeah,
6 months, what do I have to do? And yeah, I mean, when you're 65 and you're facing dentures or implants and
yeah,
getting that is very enticing, or if you don't have the money for a supplement, zero payment
Absolutely.
sounds really good. It's making, I suppose
but it's then what happens if you have something
that,
really,
yeah,
if you start to need a lot of hospital care, as many people do
Yes.
as they age.
yeah, and when that happens, and we've got to find something that protects both the people and the regular supplemental, because if that gets more expensive, there'll be more people going to the no pay plan, which I'm sure is pretty limited. But
Yeah, there's no question that's
Yeah.
complicated. I think it's important. I really just wanna leave behind again that we're really concerned about the ability of, we're seeing tremendous losses. Some of our agencies have tremendous operating losses and are starting to spend down their reserves. We have one agency this year that's closing. So the impact on the providers is significant, and of course, when you impact the providers, you impact everyone they
So
serve.
the idea
So
is
this
they
job.
could do it cheaper than Medicare. And I mean, it was a compromise to keep people from privatizing the whole thing. And yeah, they're doing it cheaper, but they're gonna close you down. And hopefully Congress can't do anything. But somebody's gonna need a nursing home eventually and find, if they can't find one within 50 miles of their home. And maybe that will swing things, so. Okay,
Okay, well, I appreciate the opportunity to share with you some of what we're seeing in the providers community on this.
good for you.
Yeah.
Good to see you, okay. Oh, thank you.
All those,
All those healthcare
it was
people.
the same crowd.
It is definitely a crew of usual suspects.
Committee, we do not have Lydia coming in until 2:30. You might want to take a 10-minute break so you're back. And we are going to start our